It's Monday, June 3rd. I'm Adam Walsh, and this is The Signal. Today on the show, here's a question. How do we talk about mental health and addictions? How should we talk about them, and how are we doing when it comes to stigma? Some big questions, and I've got quite the group here in the studio to give us some perspective on all of it. And yes, we're on the heels of Mental Health Awareness Month, and guess what? The conversation continues into June and beyond because these conversations about mental health and addictions need to happen all the time, right? Doesn't matter the month, doesn't matter the day. And here in the Signal, mental health is one of the main topics that we try to stick with throughout the year. Here with me, we've got a full group here in the studio today. So here with me, we've got Sharon King Campbell, Day Boyle, author, playwright, actor, producer. We've got Leah Lewis, author for the Dialysis Project, also professor in counseling psychology at Memorial University. Dr. Hassan Khalili, psychiatrist, author of A Life Spent Listening. And Sarah White, LifeWise Provincial Operations Manager. How you doing, folks? Thanks for coming in.
Great. Thanks for having us.
Sharon, let's start. Tell us about Day Boyle.
Okay, Day Boyle is a play that I wrote in a playwriting class that I took in 2018. And at the time, my husband's hometown on the Burin Peninsula had experienced kind of a rash of suicides. They lost 6 men between the ages of 30 and 50 who seemed to be in good health right up until they died. And as a result, 2 of the widows approached the media and the government to do an audit of the mental health services available in the area. And around the time that I started this playwriting class, the results of the audit came back that, in fact, there were not only were there supports in the region, but those supports were undersubscribed. The people in this area were not using the public health nurse and the social worker available. And that really surprised me, and it really did not surprise my husband, who had grown up as a man in that society. And so I was already writing a play, and it very quickly became a play about this.
Yeah. And for your husband growing up in that society, why did it not surprise him? I
think he understands innately in a way that I didn't, that it's the man's job to be stoic, not to need help. Like, there's a lot of gender role in the world that he grew up in, and it's really hard to break out of that, to admit that you need help, to be seen by the people in your community going to the mental health supports. Yeah, to be noticed for needing that help, because people talk. And so really Day Boyle is about that. It's about what people talk about and what they don't talk about. Mm-hmm.
So, I mean, that just sets the stage perfectly for the conversation we're having today. Also, if folks want Day Boyle, where's it available?
So it's published by Breakwater Books. You can get it from their storefront or from their website. If you just Google Breakwater Books, you'll find it. It's also available through Indigo, Amazon, anywhere you would buy a book.
Okay. So any thoughts for the rest of you here in studio on what you just heard there for your own professional capacities?
I can make a comment.
Yeah.
I've been practicing for 40, 50 years.
Yeah.
I remember when, 35 years ago, I set up my practice in a GP clinic, in a family practice clinic. People wanted after hours appointments. Mm-hmm. People wanted not more time when it's crowded and they hide someplace. They still feel a bit of shame of going to see. The numbers that people was using was a lot lesser. But past 10 or 15 years, because of a show like this and talk and that book like that, people are using it. You could see the number of psychologists, the counselors increase, and still waiting list for them. So thanks God that's happening.
Well, it's such an interesting point just about when you started folks wanting the after hours bit, right? Which speaks to stigma around it,
Yeah,
right?
yeah.
And where we were and where we still are. But like you said, there's progress which is being made. We are talking about it more on the air, and also just I find my social circles, folks are a lot more open now than growing up. At least from what I found for talking about mental health and addictions. Leah, what about yourself? What do you think?
Well, just responding, just some of what Sharon was saying. I think stigma definitely still exists.
Yeah.
And what stood out for me is the gendered aspect of who feels, who enters into a mental health. Who's able to enter into a mental health service and feel social permission to do so. And I do think that the gendered piece is like fed by kind of what our dominant stories are about what is, that stoicism means strength, and that to be anything other than that is some form of failure. And so I actually think that that male and male-identified folks often have to. It's a burden. There's a burden. It's a battle a little bit where there's less of a sense of permission to step into vulnerable spaces like a counseling space or seeking out mental health services.
And tell folks a bit more about your professional background and also and about your book, if you could.
Sure. So I teach in a counseling psychology program. So I train counselors as part of my role, and I also co-own a private psychological services practice. So it's
Coastal Health, right?
It's called Coastal Health, that's right. And we offer multiple services in the mental health realm, but also complementary services, so speech pathology and occupational therapy, which are services that also overlap with mental health, for sure. So I definitely wear multiple hats in this field, and my research looks at the psychology of chronic illness and how chronic illness, sort of shapes our development and our sense of identity. And so my play, also published by Breakwater, called The Dialysis Project, is a first-person voiced narrative of my story. So I use autoethnography in my research in working with patients who live with chronic illness to kind of look at sort of the nuance of lived experience of chronic illness and how it shapes identity and our sense of who we are in the world. So there's a lot of kind of mental health pieces that come up when it comes to chronic illness. And the Dialysis Project looks at how identity is shaped by an experience like dialysis. Yeah.
Well, I find it interesting we talk about how we talk about mental health and addictions in this province, but also then you have folks writing books, another way of, kind of communicating in different ways around what we found, right? Around the importance of talking about it and just how that kind of works its way into the ecosystem and to get on folks' radar. I want to go to the peer-to-peer side of it with Sarah White from LifeWise. Can you just tell us how you got involved with LifeWise first, and then we'll go from there?
Yeah, absolutely. So I've been in the nonprofit world for about 2 decades or so.
Yeah.
When the opportunity came up with LifeWise, a lived experience organization who empowers the voices of those with lived experience. It's a lived experience organization from board of directors on down. There's about 50 team members with the organization now, from here to Happy Valley Goose Bay. The work is just incredible. So there's 3 pillars with LifeWise. It is public education. So we have individuals with lived experience teaching assist and mental health first aid, as well as a number of other trainings. But we know the number one way to combat stigma is through contact-based learning. And having individuals who can safely identify as having lived experience, knowing that they're not going to have any repercussions from their workplace or anything like that, because a vast majority of folks can't. So we have the privilege of being able to identify with our lived experience of mental health and or addictions, and being able to share that during the mental health and or assist trainings is really powerful, and people are then feeling more empowered to speak about that. So it does reduce the stigma. We also do a lot of policy consultations with the decision makers, so a lot of advocacy and just speaking about what we hear. We have about 2,200 contacts with individuals in Newfoundland, Labrador every single month. And that ranges from substance use, to mental health needs, everything in between. We have our team members that are embedded within all the FACT and ACT teams, so the Flexible Serve community treatment teams, the harm reduction teams, Stella Circle with Just Us, and the Naomi Center, Thrive through the Blue Door program, and all folks have the specific lived experience that they are supporting within. We also know that, there's about 50% of people are going to be diagnosed with a mental health and or addictions illness in their lifespan, but not everybody's comfortable or able to speak about that. But we do know that the numbers are out there. Additionally, speaking to what you were talking about with the gender base of this, sometimes the gender absolutely sometimes plays a role, and a lot of that is how we were raised and how we talked about, boys don't cry, boys don't show their emotions, all of those pieces. But we also have a first responders warm line, and the first responders warm line was asked for by the first responders as a way to debrief before going home.
Yeah.
And that's another piece to think about, careers that folks are in where you're expected to be the person to take care of others, but who takes care of you? And then to speak to your point too about, the after hours, wanting after hours appointments and things like that. We hear from first responders a lot, like in small communities and rural communities, that you can't go to the emergency room and seek that support because those are the nurses and doctors and professionals you're interacting with while you're supporting others. So there is still a lot of stigma. There's a lot of complication around getting that supports now.
Dr. Khalili, what's the difference between mental health and mental illness?
Long question.
You're like, how many shows do you have?
Really, in the sense, mental illness is upon the degree of it. Most of the time, when the personality is sick, or there is a degree of the emotional sickness is there, or there's diagnosis there, schizophrenia, bipolar, but these are a small percentage of population. The bigger population, they have difficulty with expressing themselves, negative thought, they have emotional problem. The majority of people experience mental health issue.
Yeah.
Not necessarily mental illness always. But some of the nowadays, when we see all the trauma has happened to people, we realize we cannot distinguish them too fast to say, well, this is this is that, because some people may carry trauma all their life and they don't speak about it, so they don't make content for that statistic. So the more we talk about it, the more people will realize what the difference is, and mental illness is more severe. Mental health is, to me, is we all have mental health issues. We have pneumonia and we have cough. The difference between mental health and mental illness is the same thing.
Yeah, right. And for mental health, I guess it can also depend on different factors, for everything from rest to work-life balance to like what you're eating. I mean, all those things must have impact on it.
From my experience, most people have problem with negative thinking, and negative emotion. A few months ago, I was talking to a young lady who they have very small interchange between boss and her. And she decided to be angry for almost a month and a half. But she didn't know that she can learn, be angry for an hour and let it go. So, but some people carry some of these, I call it in my book, I call it mental emotional fat. You carry a lot of fat, emotional fat over the years, beat them. what happened in my childhood, what happened with my first job, second job, failure in school, and so by the time they are in adult, the gigabytes of their subconscious is full of these mental fats. So, and a good counseling would probably can help them to release some of that, let them go, become more fit, emotionally and mentally fit.
Professor Lewis, what do you think about what the good doctor's saying?
I would agree. I do think that there's, folks are likely, and a lot of the people that I work with have a lot of what I would call kind of self-deprecating thinking that they wouldn't apply to someone else. There are these kind of discrepancies. I think there are many people who navigate mental struggle like depression or anxiety will have a self-deprecating narrative about themselves. I'm no good. I could never do that. I've always been dumb, or like have all these kind of
some kind of a narrative is there,
a
and
narrative
you've
that is
built
ever
on it over the
present.
years.
And like if I said, so is this if your best friend was sitting here in this room with us, what would they say to hear you describing yourself that way? Oh, well, they would totally disagree with me. They would say, actually, I am, and then immediately list, a set of, proactive traits and very healthy traits. So I do think we often run into and kind of depression and anxiety, which is rampant at the moment, and COVID has made it worse, has created this kind of failure, self-deprecating narrative in folks that I think those of us who work in counseling and psychotherapy encounter that. And I'm sure in peer as well. The piece I wanted to add is that
yes, please.
I think every type of counseling or mental health service doesn't work for everyone. And I think the mental health conversation has been very valuable and important in the transparency. But I do think that, and it's coming up in this conversation, so I just wanted to say it out loud, that we talk about mental health as if it's its own category of health, but it's actually so pervasive and present in every domain of health. Even it's in just from the chronic illness piece, communicating with your health providers and feeling like you're being heard and feeling like you've got agency in your own life and world. And if that is not met by your health providers, that is going to create complex mental health response.
Oh,
right?
We just did a show last week on MS, right, for Multiple Sclerosis Awareness Month. And guess what? A big part of that conversation was about mental health. Right? Mental
health, yeah, and probably and also how the expertise of the individual gets acknowledged by health providers, and that's such an important. And I just feel like mental health is present in every room. And so maybe the conversation needs to kind of shift to not that the naming that category hasn't been a really beneficial thing to do, but even listening to this conversation, like it's in, the Buren on this tragedy on the Buren, and also just access as well, like who chooses to access what, like folks who are marginalized and who've had bad experiences with clinical types of counseling services are less likely to feel safe and trust counselors in clinical spaces. So they're going to feel safe with nonprofit groups.
Yeah, well, it's about putting a mental health lens on everything, right?
Yeah, and I think that's sort of that consideration. Yeah, it's pervasive. It's in every space. And I don't think we can peel it away.
No, Dr. Khalili.
The reason I was to put my hands up, one of the things that we have difficulty, we make mental health accessibility or mental health, talking about it, make it bigger with big words. Sometimes simplifying it, but be honest with it. Jokingly, I call the other side, when you mentioned it, about I call him Jack.
Yeah.
So if we all know our Jack, like, whether habits, whether it's passed, and be able to talk about it, and with especially with the counselor that they are down to earth and they are not talking big words and because look, old days everything was diagnosis and big words. Now simplifying it, be realistic with it, help people understand, and that's what help with even the relationship between counselee and counselor. Make it easier.
Yeah, folks have to understand, and then when it comes to like peer-to-peer support, that's a big, like, it's folks feeling they can identify because it's, well, hey, we've got a similar type of there's lived experience. We know that, like, I know the person I'm talking to on the other line has this. But then what, like, with LifeWise, what types of coaching do you do around these conversations that peer supporters are going to have?
Points.
Absolutely. So all our team members have trained peer support. So they all know and have trained in setting these boundaries to ensure that, the relationship is kept as a relationship, not a friendship. It doesn't devolve. Also ensuring that everybody leaves the conversation just as safe, if not safer, than they arrived. Because often what can happen with informal peer support is sometimes somebody may dive a little too deep and they may, open wounds that they're unsure of, or the conversation may end before the person has had a chance to wrap up, or the supporter may accidentally overshare themselves and then they're stuck with those intrusive thoughts as well.
It's almost like a trauma dump or something.
Exactly.
At that point. Yeah.
So trained peer support, the goal of that is to avoid that and ensure that everybody's safer when they leave than when they arrive. We also, because peer supporters all have lived experience in the area that they're supporting folks in, the people already automatically know that when they're speaking about their experiences, you can come back and say, okay, well, when I experienced this is what I did. But we never save, set straight, or revise. That's our goal. We believe in self-determination of every person to be the master of their own journey, and that the person knows at the end of the day what it is that they need best. Peer support also within the step care model falls within like the low to moderate area. So for folks who may be experiencing anxiety, isolation, loneliness, those type of things, that's kind of where peer support would enter. We definitely have folks who come to us when they may be in crisis, folks who are entering recovery for substance uses, all kinds of things. But there is a model of care in place where people can enter or leave the system where needed. So for peer support, it would typically be, there's self-directed supports virtually. There's all those type of things. There's peer support where the person is meeting you where you are. We have groups, we have pieces in person. We also have our provincial warm line where folks can reach out between 10 a.m. to midnight, 7 days a week, 365 days a year. Again, trying to be proactive. 811 can also connect folks to the warm line. So if somebody's calling in and they're expressing mental health and or addictions concerns, they can then be transferred directly to the provincial warm line. Similarly, people can access the first responders warm line for the same reason, knowing that they're going to connect with a first responder. The goal is providing hope and reducing stigma at the end of the day. So all of our peer supporters, because they have lived experience, and I'll use the Opioid Treatment Hub as an example. We have individuals working within the opioid treatment teams, and they're all peer supporters who have lived experience with opioid use. And some have gone through the methadone and Suboxone program. So then when they're meeting folks who are walking in for the first time, the person's really nervous and they can say, okay, I've been here, I've sat here, I've done this, I have this experience, I've gone through the withdrawals. They can speak about that, they can speak about the program and explain what's about to happen next. And then the person automatically is like, okay, you do get this. Whereas sometimes when speaking to someone who doesn't have that lived experience, they can't quite understand what that withdrawal feels like. And so it automatically inspires hope for the person too, because they're like, oh my God, you sat here and now you're the person supporting me. So that is the power of peer support.
And like if you're a first responder reaching out, it is so important for like to have another first responder who knows what it's like to be a first responder. It's the same as you look at the military for folks, you look at police, like a lot of different folks. It feels so good to have someone who knows what it's like to wear your shoes, boots, whatever.
And to speak to the pieces that aren't often talked about. So a lot of times first responders go home and the only person they debrief with really is their family members. And then that can be, they don't want to traumatize their family members with things that they've seen or just experienced. Oftentimes they'll come from one scene, literally get a shower and go to another scene without the opportunity to debrief. And there are debrief processes in place, but a lot of first responders are taught, okay, that's a part of the job. That's just the nature of it. And being able to have that debrief and talk to somebody who's experienced that, the sights, the smells, the sounds, everything is just so impactful for folks.
Sharon, as you were writing Dayboil, what was it? Because you mentioned, talking to your husband about he wasn't surprised, you being surprised. The process of yourself and the learning you did as you were writing it, what was that like for just this whole thing?
Oh, wow. Well, I wrote this really fast, actually. Yeah. This is my second play about mental health.
Yeah.
I kind of have a bee in my bonnet about it, especially the stigma end. My experience with mental illness ending in tragedy is as a survivor, as a person who loved someone who died as a result of their mental health. And so when I started writing this play, before this audit came out, I was writing a kitchen table comedy for 4 women. I had just written something really like angry and sad, and I was like, I'm going to do something fun, and then it took this like very sharp turn into the tragic. But the 4 women are still the core of it. Yeah. So the story is told from the widow's perspective of the man who kills himself in this story, and it is because my lens on this is so gendered. Like the female caretaker of the man who is struggling in silence. That this play is about how women take care of each other and also of the men and boys in their lives, and what's expected of women as caretakers that isn't expected of the men. So that's really kind of the focus of this play. It's interesting to hear this talk about first responders, because actually the main character in this play is a paramedic. So she comes home from her traumatizing work and is faced with a partner who is in so deeply in depression that she can't get any response out of him at all. So that's sort of the prelude to what happens in this piece.
From your description, like it is for me, it's like such a Newfoundland and Labrador story that I can easily picture. Right, the kitchen table, which is the paramedic spouse coming home, like all of this is stuff that I could see in every single community of the province easily happening, because it is based in reality and also lived experience and everything else. Even though it's a play that you're writing. Yeah,
it isn't. To be clear, this isn't the story of someone in particular. This is a story that could take place anywhere in Newfoundland, and actually, its first production was set in Cape Breton.
Right.
It was the first production took place in Nova Scotia, and the artistic director who programmed it and the director who directed it saw Cape Breton in it, and so they set it in Cape Breton. It's a really, I think, an unfortunately ubiquitous rural story.
You're listening to The Signal, and today we're having a conversation around mental health and addictions, and we're asking, how do we talk about them? How should we talk about them? And how are we doing when it comes to stigma? Here with me in the studio, we've got Sharon King-Campbell, author of Day Boyle, playwright, actor, producer, Dr. Hassan Khalili, a psychiatrist, author of A Life Spent Listening, Leah Lewis, author of The Dialysis Project, professor in counseling of psychology at Memorial University, co-owner of Coastal Health, and Sarah White, LifeWise, provincial operations manager. Here's a question. When it comes to mental health and the ability to find help for what you need in this process. Like we're hearing there's lots of stuff that we hear, right, from counseling available to LifeWise and a warm line. But at the same time, we talk about a crisis in healthcare. We're looking at a health accord trying to reinvent the healthcare system. How are we doing for what's available, and what more do you think needs to be done?
I'll start,
sure.
I guess.
Thanks, Leah.
Well, I think our province has, in good faith, done all the policy work to lay the groundwork that forces everybody's hands to commit. It just takes time for policy, and I'm just going to spend a little tiny bit of time on this because this is the kind of thing that puts everybody to sleep, which is, one of the hats I wear is working towards regulation of counseling experts, counseling trained folks who have counseling psychology degrees or comparable degrees who are working clinically, but they're not. Because there's no regulatory college there, they're not in the health system.
Yeah.
And so they can only well, not only, they are available through all the nonprofit agencies that support mental health and provide mental health services, and also through private practice. So regulation is a policy that was recommended by both all-party reports that came out over the last decade, one in mental health and addictions and the other in education, that there's a real need for a diversification of mental health access in our province. And to translate that, we need more types of mental health provision and different avenues of access. Because I said a few minutes ago that, folks who are highly marginalized and who've had really traumatic experiences with the healthcare system are not going to trust the healthcare system to provide adequate mental health, but they are likelier to trust a peer support, an agency like LifeWise or the Gathering Place or Choices for Youth or Stella Circle, where that is a community-embedded agency that have really skilled. And so we have to be creative about how we support mental health, because we have this notion of mental health being the kind of thing that I do, like come into my office and have a confidential, vulnerable exchange, which is what many people certainly respond to, and it really helps. But for others, that doesn't work. Like for others, it has to be a peer group, or community embedded.
Or like a Choices for Youth type of a community health center. Because we've had them on the show talking about this before, where you've got like a social worker, someone else who's trusted, making relationships with folks who perhaps won't go across town on the bus to go into the health sciences but they will do something there, and that's the entry point because you're meeting folks where they're at. And
also, Choices for Youth have a variety of programs that foster agency and autonomy in youth and young adults. And these are kind of programs that are not necessarily sitting down talking about your mental health crises, but maybe you're learning a skill. Maybe they have carpentry programs at Choices for Youth. And the agency and the autonomy and the confidence that evolves out of these hands-on applied programs that are run by skilled folks in the mental health field can really create seismic changes in people's lives.
It's such an interesting mental health conversation, right? It's like, it's a mental health conversation, but it's someone learning a skill like carpentry, right? But you look at the upskilling of what that individual is getting, the confidence that they get, plus everything else. It's fascinating.
Well, the self-worth that comes out of gaining confidence and gaining a skill, and like for me, mental health provision is really about fostering agency and self-worth in the individual, and finding finding in our conversation and our exchange. I want that person to love themselves and to feel confident in themselves. And I'll just say one last thing before we open it up to the group. Like the field of counseling is really moving in that direction, right? Is in a very client-centered relational model that is really accessing the strength and agency and helping individuals recognize that in themselves. And I think that's what stepped care tries to do and what peer support tries to do. And the single session models are really go right to how are we going to grow strength and agency. And then so that intervention, like seeing a counselor, is not something that's going to last years upon years, but might be a few sessions, and then I'm going to go out and try this.
Yeah.
One of the things that I wish I was time was back. If we could even do things in elementary school, in high school, we become part of curriculum that we would be able to introduce what is really mental health is and what kind of thinking habit, what kind of emotional regulation you can learn. It is a thing that it can be easily taught, but with simple languages to people. But unfortunately, what we perceive counseling or going to see a psychologist or psychiatrist only is mental health services. The thing that you mentioned is we need to go to bottom of the society and start teaching them, if you feel this way, that means this. If you behave in this way, if you don't exercise, it just means this. If you have memory problem, that means this. If you have concentration problem, that means this. If you have bad sleep hygiene, that means this. But we forgot to tell you, I am a psychologist, not a psychiatrist.
Oh, psychologist, yeah. Sorry. Psychologist. Sarah, what about yourself?
So just to speak to a little bit about what Leah was saying, I think a lot of times when we were maybe growing up, and maybe a generational thing, and it may be an educational thing, when we think about, people start having struggles with their mental health, maybe their anxiety is increasing, maybe they're feeling symptoms of depression, maybe there's things happening in their life, there's been a traumatic event. A lot of us who were born and raised in the 80s and 90s always were led to believe okay, I need a counselor, I need a psychologist, I need a psychiatrist. So we know there are huge wait lists for psychiatrists right now on the island. However, for people just to know that there are other access, Newfoundland is so very rural. To be able to have an in-person sit-down meeting with everybody who needs access when they want access and when they need access, it's just it's just not something that's realistically going to be able to happen. But there are so many virtual options. There's so many one-time options. There's so many things that you can do self-paced. All of those pieces do exist. I do think at the end of the day, if we're really going to address the mental health and substance use challenges that we're seeing, we really need to address the social determinants of health. Yeah. A lot of the times, finances, housing, those type of things, socialization, social connections,
totally,
they all interact. They all affect our mental health and our behavior so much, and can eventually lead to a mental illness or a diagnosis where we do need higher levels of support. So if we can meet people before they reach that point, then that's what we're going to be able to do to really help with the kind of the backlog that's happened in the system, and educating folks in the fact that not everyone's going to need to jump right to a psychiatrist.
Yeah.
There are other entry points, and that you as the individual who's experienced this are the best person to make that decision for yourself. But it comes down to education too.
Yeah. I really wholeheartedly agree with what Sarah just said. And that just as a concrete example, folks who don't have a home address cannot register for a GP. They can't apply for a job. You can't gain social traction in order to help. So there are basic social determinants. And this is what I was saying before, it's such a, mental health is everywhere. And it is and what Dr. Khalili was saying, the social, emotional part of development is not received. It is now. The kind of social emotional, there's a social emotional model that is part of the school system now that has come in as a result of our all-party reports, the CASEL model, social emotional learning model, that does tap into emotional regulation, how we engage in relationship, et cetera. But Sarah's right that unless there's kind of we gain traction in things like housing and Medicare and frontline service provision, the mental health piece is very present in all of that.
Yeah. We're thinking of addictions in this province. I do think when it comes to the culture around drinking, where are we with that? Is it how unhealthy is it in this province, or healthy, depending on where you are with it? Dr. Khalili, what do you think for addictions?
I think addiction is getting worse.
Yeah.
Even there are more services available, and everybody is looking for a short-term solution to their emotional problem, and they think by drinking may do it, but drug will do it. But the fortunate part of it is that only a percentage of people are doing it. A lot of people are aware, and they don't get involved to begin with. But to me, maybe we have more statistic now, but it's worse than 10, 15, 20 years ago.
Oh, yeah.
But it's sort of accepted that, a little bit pot is okay, a little bit of this is okay, a little bit of that is okay. And while we could become more clear as we go along, and we the advantage of, for example, marijuana is becoming more obvious, but regulated, and that's make it different. But if you're asking me, the addiction is getting worse, even though the treatment is becoming more And thanks God, we have better counselor, better social worker, better psychologist, better psychiatrist. We have more educated people with addiction.
Yeah, more folks who can help, but at the same time, you're seeing like addictions getting worse. Any other thoughts on that?
Canada Health put out that.
Oh yeah,
right.
Yeah.
That what is it? 1 or 2 drinks a week. What is
they're
the
like pretty much saying don't. Like it was pretty much any is bad for you, but if you're going to like 1 or 2 a week or something like in that.
Yeah,
area.
and I think the history that Newfoundland and Labrador have with alcohol is long. It's definitely part of the culture. It's part of kind of community. It's how we celebrate. It's how we celebrate weddings and funerals, and so that message, I'm not sure, this is just opinion, I haven't read an article on it or anything, but that I'm not sure, but I suspect that these kind of research results that are being announced across the country are not being clocked.
Yeah.
And it kind of, I don't think that it's being clocked. I do think drinking, which is what you specifically asked about. I agree with what Dr. Killilly said. It's a longer conversation because addictions are newer. Like drug addictions are a newer phenomenon in Newfoundland and Labrador, but alcohol is an old friend.
Yeah.
Mm-hmm.
And I'm not sure how to grab that tail.
There's one more thing about mentioning that. The alcohol, when you think about it, close your eyes, you think about it, most people see it as positive. Versus addiction is a negative. I don't know where is the crossroad between the two come, because when we're thinking of happiness, alcohol comes with it.
Yeah.
So there's a positive image of it, even though we talk about the negative image of it. As long as this becomes clear, people who have addiction versus a person who take a drink here and there, that's a different story.
Well, and then you look online at the memes and everything else. It's like, the joke about the glass of red wine for mom or something, which you see a lot. Or then there's like so many other ones. So like everything's ha-ha funny up until it gets to the point where it's stigma, and then it's a whole other issue altogether.
When somebody come to me, he said, if I said to me, I want to stop smoking, or I want to stop drinking, versus I should stop smoking. Yeah. The second one is harder to deal with because they're not ready to get rid of it.
Sharon, you're going to say?
And before I dive into this topic, I just want to be clear that I don't have any training. I just role play. Yeah. But I also recently had a baby. And there was a period of time when I was pregnant and didn't want to drink alcohol, or we were trying to get pregnant and I didn't want to drink alcohol, and I really didn't want to have a conversation about why I wasn't drinking alcohol. And as a result, I learned to like 0% beer.
Yeah.
It is so hard to exist in this society without a drink in your hand at many social occasions. And that's obviously a problem as we come to understand exactly how dangerous alcohol really is to our health. And in this piece, there's actually maybe the funniest scene in this play is that Day Boyle, I think, just to be clear in case you're not up on the vernacular here, Day Boyle is a word for getting drunk in the daytime. Yeah. And what happens is that this widow comes home from identifying the body of her husband, and she starts drinking, and she drinks all day. And part of that process is that she gets her friends to help find all the places where her husband has hidden alcohol in the house, because his depression has become addiction. His depression led to an addiction, because it's so normal to drink your troubles away. It's radio, you can't see my air quotes, but we're drinking our troubles away. It's so normal to get together with the guys for beers, and maybe that's the only time you ever get to talk about how you feel, because you're drinking enough that your inhibitions are gone and you're
finally sharing, right?
Yeah.
It's the only time you can share is like in the shed with those drinks.
Exactly.
Or whatever.
Yeah.
And
go ahead.
the difference is between somebody who has alcohol problem versus somebody who has addiction.
Yeah.
The person who's addicted of the disease of addiction should not even have a sip.
Yeah.
Yes.
Yeah.
But people who have they become moderate, they can do whatever they can use alcohol as moderation. But we don't know where the boundary passes. When the addiction become more than actual the disease.
Yeah.
I encourage people who have, if they have sense that they have addiction, and there is tests to be done they can't drink even a sip.
Yeah.
I grew up in society that alcohol were prohibited.
Yeah.
But people still drinking.
Yeah.
Because they were still addict there.
Yep.
Yeah, even though back when you were growing up in Iran,
I've been away most of my life, so I don't know which one.
Yeah, of course. Sarah, any thoughts?
Absolutely. Just as Leah said, like the topic of substance use and addiction is just a very big one. So to try and keep it a little bit shorter is, within the Newfoundland Labrador culture, drinking specifically is, it's a part of the culture. We have the most bars per capita anywhere in the world in George Street. And it is so rural, and it is one of the things, like, people get together, they go in the shed, and they have some beer and all that kind of stuff. So it really is embedded. However, one of the things that we are learning now, because when you know better, you do better, is more education out there about the harms of alcohol. How do you know when it's starting to become a challenge for you, and some of the supports that exist? We also do know a lot more about harm reduction and the importance of harm reduction. So abstinence doesn't have to be the only way. Reducing the intake, recognizing when stressors happen, replacing that with a different activity instead of drinking. All of those pieces can help, and there is additional supports in place right now. But when we look at addiction and substance use, we definitely need to look at the harm reduction model, because abstinence isn't going to be the answer for everyone. It's not going to be something that every person wants, just as though someone who has a mental illness, not every person is going to want to take prescription medication. So it's very similar. There's still so much stigma around substance use disorder. And like within the mental health field, we're seeing a stigma reduce, people talking about it more, people having a better understanding, all of those pieces, and especially in the younger generations. But when it comes to substance use disorder, the stigma is still so very, very high. And the knowledge and understanding of harm reduction methods is still quite low, and there's still a lot of myths and misconceptions around there about that. But I couldn't let this go by without saying, harm reduction does play a role here. Education, as always, knowledge is power, so the more people know, and we can definitely see that even in talking to some of our youth, like they recognize and they know the dangers that exist with this. Of course, we are in a different time. There is increased substance uses in some areas, but the importance that harm reduction plays in that, and the importance of people's choice in if they choose to use or not use is so very important.
Can I ask something? It's still on topic, but here in St. John's, I know the rest of the province might be experiencing different weather, but growing up, I would always hear about seasonal affective disorder and everything else. And now here we are in June, and it's just we're caked in with fog again. Any tips or thoughts for folks who, when we talk about mental wellness, mental health, sometimes you just need a sunny day, but and you don't always get them here. They're not on order. What's your advice for folks around just trying to get through day to day with this type of weather, and how it can impact you?
If we live here, we experience this, so we can complain about it, or we can become creative. Positive thing we can do. I learned it. I've been here this many years, and we had 10 days of rain. We had 280 days of rain. So we can excuse ourselves to become down, or we can become creative, and that's compared to many provinces, we are happier people. So, because people learn, except alcohol, they will learn to we have a beautiful outdoor. Being able to even to this, some people love to go to outdoor.
Yeah. So
we have to be creative about what kind of positive activity we can do, even connecting with people, having a garden, or having a flower inside of our offices, a pet, and.
Leah, what about you?
Agreed. I think
be creative. Yeah.
I think part of it is that I do think that the environments we live in shape who we are as well. So I do think there's some resilience that comes with the climate that we live in. And it's not lost on Newfoundlanders that, you know, the month of June is nicknamed Junuary. But I do think there's a small sector of the population that genuinely struggle with seasonal affective disorder. And there are recommendations in the dark months and in January for bringing light into your space. So there's like sun lamps that you can have, and there are other kind of small interventions that can be used for folks with whom just being exposed to a sunlit room is actually connected in a very a very specific way to their mental health. But I agree with what Dr. Killilly says. I mean, I think part of what I do when folks are struggling is, well, so, you know, what part of your day brings you, you know, a little bit of joy? Or what part of your day do you enjoy the most and why? And concretely, to use my example, it's my morning coffee, right, and walking my dog, and to be able to kind of to demystify what it means to help ourselves feel a bit better, just a little bit better, and that can possibly be at an arm's length thing. So, you know, if you're then do you like, you know, is a Subway sandwich a particular treat for you?
Yeah.
And I mean, I think some like these like tiny like micro moments of joy or micro moments of relaxation or contentment, whatever you want to call it, is very accessible, but it changes from person to person. It's context driven.
Yeah, it's not going to be a Subway sandwich for everyone, but for someone it can be, right?
Yeah, that's right. Yeah. And for some it'd be like Subway. But, you know, so I do think, you know, I say some folks definitely need to kind of be intentional, and others, I think you can tap in to these moments.
I call it creating cream puff board instead of our head. You basically create a beautiful world inside of your head. You can close, you go there. And swimming is another one. Showering, spending time with friends, relaxation exercises. These are all the things you can do. But still, we acknowledge sometimes it's too much of it.
Yeah.
Yes.
So you can curse a bit for 5 minutes and then stop.
Yeah, right? Yeah. Don't let it just, you know, weigh on you. For nothing like look, everyone go outside, raise your fist at the fog, have a good shout at it, and then move on with your day.
Yeah, be mindful of it, that you cannot keep it up for 3 weeks because I buy.
Yeah, I think humor is a real tool in our culture, and humor has been known to regulate the nervous system in times of trouble, and I think humor really gets applied to the weather, to the climate piece here. Yeah.
And Sharon, I mean, you've got humor through your play too, right?
Absolutely. And this is sort of a rule of thumb of theater, is that if you want to affect people emotionally, the easiest way in is to make them laugh. So we make them laugh as soon as we can, and also kind of as often as we can, as long as it's rooted in the story that you're telling. And then when you want them to feel other things, and I'm hoping that audiences of Dayboil, readers of Dayboil, will wind up feeling empathy for the character who's going through this immense grief. You have a way in if you have made them laugh first, that they've opened up enough to connect.
Can I just say one thing just about plays like Dayboil?
Yeah, about 20 seconds, but
and it's really quick. It's just when folks can relate and see themselves in performance pieces like Dayboil, that validates. It can actually make a big difference. So that's why I really like kind of using the arts to explore difficult topics, because seeing yourself in a character is very validating, and it can actually pack a big punch.
Well, and Sarah, it's the same as like that to me connects with peer-to-peer support too, right? Any final thoughts from you today?
Absolutely. When it comes to the weather and seasonal affective disorder,
About 15 seconds.
just recognizing that it is valid, and if you're experiencing those, speak to your professionals and your support team.
All right, everyone. Sarah White there, LifeWise Provincial Operations Manager. Leah Lewis, author of The Dialysis Project, professor in counseling psychology at Memorial, co-owner Coastal Health. Dr. Hassan Khalili, psychologist, author of Life Spent Listening. And Sharon King-Campbell, day Boyle author, playwright, actor, producer. That is it for today's show. And you know what? Looking at that weather outside, it means one thing. Today's Monday. Tomorrow, it's gardening day. Nothing like gardening in the fog if you're in St. John's. If you're in Deer Lake, I'm sure everything is looking great. Do get into us with your questions and comments about gardening. Dan Rubin's here tomorrow.